Assalamu alaikum. Hopefully you are doing well in this pandemic situation and welcome after the summer vacations. Uh, Today's topic is a bit dry, uh, but you have already learned this topic in your previous MBBS classes. So hopefully it will be not that difficult. So the topic of today is vitamin B and vitamin C, which are water soluble vitamins, and we'll talk about them and about their deficiencies. So first we'll talk about vitamin C. Vitamin C, commonly known as ascorbic acid as well. Vitamin C is important for synthesis of collagen at the level of hydroxylation of lysine and proline in pre-collagen. It is also involved in neurotransmitter metabolism, like conversion of dopamine to norepinephrine and tryptophan to serotonin, and cholesterol metabolism, conversion of cholesterol to steroid hormones and bile acids, and the biosynthesis of carnitine. Vitamin C is an important antioxidant in the aqueous milieu of the body. This function of ascorbic acid may be important in preventing degenerative diseases, cardiovascular diseases, and some cancers. Vitamin C enhances non-heme iron absorption, so the transfer of iron from transferrin to ferritin and the formation of tetrahydrofolic acid, and thus can affect the cellular and immunological functions of the hematopoietic system. So, in short, vitamin C is important for certain metabolic pathways. It works as antioxidant and it is important in the absorption of iron. So humans depend on dietary sources of vitamin C. The requirement for vitamin C is increased during infections and diarrhea. Children exposed to smoking or environmental tobacco smoke also require increased amounts of foods rich in vitamin C. The best food sources of vitamin C are citrus fruits, fruit juices, pepper, berries, melons, tomatoes, cauliflower, and green leafy vegetables. Vitamin C is easily destroyed by prolonged storage, overcooking, and processing of foods. Foods rich in vitamin C are oranges, spinach, strawberries, blackberries, lemon, tomatoes, cauliflower, and broccoli. Absorption of vitamin C occurs in the upper small intestine by an active process or by simple diffusion when large amounts are ingested. Vitamin C is not stored in the body but is taken up by all tissues. The highest levels are found in the pituitary gland and adrenal glands. Breast milk contains sufficient vitamin C, so this prevents deficiency in infants. Infants who are consuming pasteurized or wild animal milk, cow's milk, they are at significant risk of developing deficiency of vitamin C. Neonates whose feeding has been delayed because of clinical condition can also suffer from ascorbic acid deficiency. The disease caused by deficiency is scurvy. Children fed predominantly heat-treated, ultra-high temperature or pasteurized milk or unfortified formulas, and not receiving fruits and fruit juices are significant risk of symptomatic disease. In scurvy, there is defective formation of connective tissues, collagen, cartilage, dentin, bone, blood vessels. This leads to fragility of the vessels as well. In the long bones, osteoid is not deposited by osteoblasts due to this disease, so that the cortex is thin, trabeculae become brittle, and the bones fracture easily. The early manifestations are irritability, loss of appetite, low-grade fever, and tenderness in the legs. These signs and symptoms are followed by leg swelling, most marked at the knees and the ankles, and causes kind of pseudo paralysis. So not actual paralysis. So due to the severe pain, uh, it looks like paralysis. So we call it pseudo paralysis, false paralysis. Subperiosteal hemorrhages in the lower limb bones, they sometimes acutely increase in the swelling and pain. The condition can mimic acute osteomyelitis or arthritis. Our rosary at the costochondral junctions and depression of sternum are other typical features. Rosary just we see in vitamin D deficiency as well. But against to vitamin D deficiency, the sternum is depressed. But vitamin D deficiency, the sternum is pigeon shaped. Gum changes are also seen in children after teeth have erupted and are manifested as bluish purple spongy swellings of the mucous membrane, especially over the upper incisors. Anemia. It is a common manifestation in infants and young children of scurvy, and it is related to impaired iron absorption, as already have been discussed, and coexistent hematopoietic nutrient deficiency, including iron, vitamin B12, and folate. As most of the kids who are deficient in one vitamin, most of them would be deficient in other mineral vitamins as well. Hemorrhagic manifestations of scurvy include petechiae, purpura, and ecchymosis at pressure points, epistaxis, gum bleeding, and the characteristic perifollicular hemorrhages. We'll see in the next slide the same things. Other manifestations are poor wound healing and fracture healing, hyperkeratosis of hair follicles, arthralgia, and muscle weakness. So this is the bleeding from the gums and easy bleeding from the gums. These are the ricket rosary spots, like these rounded bony projections, and these are the changes at the level of hair follicles. How we make the diagnosis? The diagnosis of vitamin C deficiency usually in the clinical setting is made on clinical picture, and also sometimes we need radiographic appearance and the levels of ascorbic acid in the blood. The typical radiographic changes are these line of Frankel. If you see the radiograph, the line of Frankel, white line of Frankel would be there. So the typical radiographic changes occur at the distal ends of the long bones and are particularly common at the knees. The shafts of the long bones have ground glass appearance due to the trabecular atrophy. The cortex is thin, dense, giving appearance of pencil outlining of the diaphysis epiphysis. The white line of Frankel, an irregular but thickened white line at the metaphysis, represents the zone of well calcified cartilage. So this is the line of Frankel, white line of Frankel, due to the dense zone of provisional calcification. Epiphyseal separation can occur along the line of destruction with either linear displacement or compression of the epiphysis against the shaft. Subperiosteal hemorrhages are not visible using plain radiographs during the active phase of scurvy. However, during healing, the elevated periosteum becomes calcified and radiopaque, giving a dumbbell or club shape to the affected bone. MRI can demonstrate acute as well as healing subperiosteal hematomas along with the periostitis, metaphyseal changes, and heterogeneous bone marrow signal intensity. A plasma ascorbate concentration of less than 0.2 mg per deciliter usually is considered deficient. So we have already discussed this white line of Frankel, and along with this, these are the subperiosteal hemorrhages, is black. So differential diagnosis of scurvy. Scurvy is often misdiagnosed as arthritis due to pain, swelling, osteomyelitis, battered child syndrome like child abuse, or acrodynia. Like acro mean the extremities, dynia mean pain, so pain in the limbs. This term is derived from the Greek word. The early irritability and bone pain are sometimes attributed to non-specific pains or other nutritional deficiencies. Copper deficiency is also one of the differential. HSP, Enosh, Sconin purpura, thrombocytopenic purpura, or leukemia, or sometimes suspected in children presenting with hemorrhagic manifestations. Vitamin C supplements are the treatment, and 100 to 200 milligram per day orally or parenterally ensure rapid and complete cure. The clinical improvement is seen within a week, but the treatment is usually continued for 3 months for complete recovery. So this is all about vitamin C, and now we will move on vitamin B complex. So as it is uh, a combination of multiple vitamins like vitamin B1, thiamine, riboflavin, B2, niacin, B3, pyridoxine, B6, folate, cobalamin, B12, biotin, and pantothenic acid. B complex vitamins serve as coenzymes in many metabolic pathways that are functionally closely related. As you've already learned this in your biochemistry. Consequently, a lack of one of the vitamins has the potential to interrupt a chain of chemical processes, including reactions that are dependent on other vitamins, and ultimately can produce diverse clinical manifestations. Thiamine is the B1 vitamin uh, from the vitamin B family. So the dietary sources are fish, poultry, and non. These are the non-vegetarian sources for the vitamin B1, and the main sources for vegetarians are rice, oats, wheat, and legumes. Most ready-to-eat breakfast cereals are enriched with thiamine. The breast milk of a well-nourished mother provides adequate thiamine to the infants. Most infants and adults consuming a balanced diet obtain an adequate intake of thiamine from food and do not require supplementation. Early symptoms of thiamine deficiency are non-specific, as in case of any vitamin like vitamin deficiency like fatigue, apathy, irritability, depression, drowsiness, poor mental concentration, anorexia, nausea, abdominal distress. These are the symptoms of most of the vitamin deficiency. You can incorporate these symptoms in any vitamin deficiency, but like the typical disease occurring due to the thiamine deficiency is beriberi, which has got further two types, dry beriberi and wet beriberi. As the condition progresses, more specific manifestations beriberi such as peripheral neuritis manifestations are tingling, burning, paresthesias of the toes and feet, decreased deep tendon reflexes, so slow deep tendon reflexes, knee jerks and ankle jerks, loss of vibration sense, tenderness and cramping of the leg muscles, congestive heart failure, and psychic disturbances. Patients can have ptosis of eyelids and atrophy of optic nerve. Hoarseness or aphonia is caused by the laryngeal nerve paralysis. Later signs include increased intracranial pressure and signs of meningismus and coma. Uh, so two types we will discuss. The disease is wet or dry depending on the amount of fluid that accumulates in the body due to factors such as cardiac or renal dysfunction, even though the exact cause of this edema has not been explained. Many cases of thiamine deficiency show a mixture of the two main features and should be more appropriately termed as thiamine deficiency with cardiopathy and peripheral neuropathy. Riboflavin is the B2 from the vitamin B family. It is also part of the structure of coenzymes. Milk, eggs, organ meats, legumes, and mushrooms are rich dietary sources of riboflavin. Most commercial cereals, flours, and breads are enriched with riboflavin. Clinical features of the deficiency of riboflavin include cheilosis, so the fissures at the angles of the mouth, glossitis, changes in the tongue or sore tongue, keratitis, changes in the eye, conjunctivitis, changes in the eye, photophobia, fear from the lights, lacrimation, corneal vascularization, and seborrheic dermatitis. Cheilosis begins with a pallor at the angles of the mouth and progresses to thinning and maceration of the epithelium, leading to fissures extending radially into the skin, the same I was told. In glossitis, the tongue becomes smooth with loss of papillary structure. Normochromic normocytic anemia may also be seen because of the impaired erythropoiesis. So this is the glossitis, this is the chelosis angles. Niacin, major dietary sources are meat, fish, poultry, and for um, vegetarian cereals, legumes, and green leaf vegetables are the rich sources of niacin. Enriched and fortified cereal products and legumes also uh, are major contributors to niacin intake. Milk and eggs contain little niacin but are good sources for tryptophan, which can be converted to NAD. Pellagra is the disease caused by niacin deficiency. The classic niacin deficiency disease occurs chiefly in population where corn, maize, a poor source of tryptophan, is the major foodstuff. C deficiency imbalance such as in anaerogen nervosa and in war, famine uh, conditions also can cause pellagra. Pellagra can also develop in conditions associated with disturbed tryptophan metabolism such as carcinoid syndrome and Hartnupp's disease. The early symptoms of pellagra are vague, just like anorexia, lassitude, weakness, burning sensations, numbness, and dizziness. After a long period of deficiency, the classic triad of dermatitis, diarrhea, and dementia appears. Dermatitis, the most characteristic manifestation of pellagra, can develop suddenly or insidiously and may be initiated by irritants including intense sunlight. So this is the dermatitis. You can see lesions first appear as symmetric areas of erythema on exposed surfaces resembling sunburn and might go unrecognized. The lesions are usually sharply demarcated from the surrounding healthy skin and their distribution can change frequently. The lesions on the hands and feet are often have the appearance of glove or stocking. Like this is the appearance of gloves and stocking. The gloves and then the feet, the legs you can see stocking appearance. Similar demarcations can also occur around the neck, castle necklace. So this is the thing which we are discussing, castle necklace. The cutaneous lesions may be preceded by or accompanied by stomatitis, glossitis, vomiting, diarrhea, swelling and redness to the tip of the tongue and its lateral margins, often followed by intense redness or even ulceration of the entire tongue and the papillae. Nervous symptoms include depression, disorientation, insomnia, and delirium. Vitamin B6 pyridoxine. B6 is found in the human milk and good source for the infant. Good food sources of the vitamin include fortified ready-to-eat cereals, meat, fish, poultry, liver, bananas, rice, certain vegetables. Large losses of vitamin can occur during high temperature processing of foods or milling of cereals, whereas parboiling of rice prevents its loss. The risk of deficiency is increased in persons taking medication that inhibit the activity of vitamin B6 like isoniazid, penicillamine, corticosteroids, anticonvulsants. In young women taking oral contraceptives and in patients receiving maintenance dialysis, also there are risk of deficiency. The deficiency symptoms seen in infants are listlessness, irritability, seizures, vomiting, and failure to thrive. Peripheral neuritis is a feature of deficiency in adults but is not usually seen in the children. Skin lesions include chelosis, glossitis, seborrheic dermatitis around the eyes, nose, and mouth. Microcytic anemia can occur in infants but is not common. Oxaluria, oxalic acid bladder stones, hyperglycemia, lymphopenia, decreased antibody formation, infections are also being associated with vitamin B6 deficiency. Several types of vitamin B6 dependent syndrome, presumably due to errors in the enzyme structure or function, respond to very large doses of pyridoxine. Like in neonates, if the seizures are continuous, we usually, if we have ruled out all the causes, we need to give high doses of pyridoxine for the seizures sometimes. Um, after proving it vitamin B6 deficiency. These syndromes include pyridoxine dependent seizures, which I am discussing now, vitamin B6 responsive anemia, xanthourenic aciduria, cystinuria, and homocystinuria. Folate. Folate exists in a number of different chemical forms. Folic acid is the synthetic form used in fortified foods and supplements. Rice and cereals are rich fat sources of folate, especially if enriched. Beans, leafy vegetables, fruits such as oranges and papaya are good sources too. The vitamin is also synthesized by the colonic bacteria, and half-life of the vitamin is prolonged by enterohepatic circulation. So, folate deficiency can result from poor nutrient content in diet, inadequate absorption like celiac disease, inflammatory bowel disease, increased requirement like sickle cell anemia, psoriasis, malignancies, period of rapid growth as in infancy and adolescence, or inadequate utilization, long-term treatment with high-dose non-steroidal anti-inflammatory drugs, anticonvulsants such as phenytoin and phenobarbital and methotrexate. Rare causes include hereditary folate malabsorption, inborn errors in metabolism, folate metabolism, and cerebral folate deficiency. Folic acid deficiency results in megaloblastic anemia and hypersegmentation of neutrophils. Non-hematological manifestations include glossitis, listlessness, and growth retardation not related to anemia. There is an association between low metabolic folic acid status and neural tube defects, primarily spina bifida and anencephaly, and the role of periconceptional folic acid in the prevention is well established. So we need to give folic acid even before the periconceptional period, to all the uh, women of childbearing age. Hereditary folate malabsorption manifests at 1 to 3 months of age with recurrent or chronic diarrhea, failure to thrive, oral ulcerations, neurological deterioration, megaloblastic anemia, and opportunistic infections. Cerebral folate deficiency manifests at 4 to 6 months of age with irritability, microcephaly, developmental delay, cerebellar ataxia, pyramidal tract signs, choreoathetosis, villus seizures, and blindness due to optic atrophy. 5-methyl tetrahydrofolate levels are normal in serum and RBCs but are markedly depressed in the CSF. The diagnosed folic acid deficiency anemia is made in the presence of macrocytosis along with low folate levels in the serum or RBCs. Macrocytosis are large red blood cells, large size of red blood cells. Normal serum folic acid levels are 5 to 20 nanogram per milliliter. With deficiency, serum folic acid levels less than 3 nanogram per milliliter. Levels of RBC folate are better indicator for chronic deficiency. The normal RBC folate level is 150 to 600 nanogram per milliliter of packed cells. The bone marrow is hypercellular because of erythroid hyperplasia and megaloblastic changes are prominent. Large abnormal neutrophilic forms, giant metamyelocytes with cytoplasmic vacuolation are also seen. When the diagnosis of folate deficiency is established, folic acid may be administered orally or parenterally at 0.5 to 1 milligram per day. Folic acid therapy should be continued for 2 to 4 weeks or until a definite hematologic response has occurred. So folic acid therapy should be continued for 3 to 4 weeks or until a definite hematologic response has occurred. So if the child is anemic, so you can do the complete blood count again after 1 month. If the hemoglobin is still low, you can continue the folic acid therapy along with iron. Maintenance therapy with 0.2 milligram of folate is adequate. The last but not the least, vitamin B12, cobalamin. Vitamin B12 is the form of deoxyadenosylcobalamin, functions as a cofactor for the isomerization of methylmalonyl CoA to succinyl CoA, an essential reaction in lipid and carbohydrate metabolism. Dietary sources of vitamin B12 are almost exclusively from animal foods. So the people who are strict vegetarian, they would be deficient of vitamin B12 unless their diet is fortified with the vitamin B12. Organ meats muscle meats, seafoods, mollusks, oysters, fish, poultry, and yak yolk are rich sources. Fortified ready-to-eat cereals and milk and their products are the important sources of vitamin for vegetarians. Human milk is an adequate source for the breastfeeding infants. The vitamin is if the mother is not vitamin B12 deficient. The vitamin is absorbed from ileum at alkaline pH after binding with the intrinsic factor. Enterohepatic circulation, direct absorption, and synthesis by the intestinal bacteria are additional mechanisms helping to maintain the vitamin B12. Vitamin B12 deficiency due to inadequate dietary intake occurs primarily in persons consuming strict vegetarian or vegan diets. As already discussed, prevalence of vitamin B12 deficiency is high in predominant vegetarian or lacto-vegetarian populations. Malabsorption of B12 occurs in pernicious anemia, you know very well, due to intrinsic factor deficiency and ileal resections and Crohn's disease. Breastfeeding infants of the B12 deficient mother are also at risk of significant deficiency, as already discussed. The hematologic manifestations of vitamin B12 deficiency are similar to manifestations of folate deficiency. Irritability, hypotonia, developmental delay, developmental regression, and involuntary movements are the common neurological symptoms in infants and children, whereas sensory deficits, paresthesia, and peritonitis are seen in adults. Hypersegmentation of the knuckles and hyperpigmentation of the knuckles and palms is another common observation B12 deficiency in children. Diagnosis: the hematologic manifestation folate cobalamin deficiency are identical. The anemia resulting from cobalamin deficiency is macrocytic with prominent macrovalocytosis of the RBCs. The neutrophils may be large and hypersegmented. In advanced cases, neutropenia and thrombocytopenia can occur, simulating aplastic anemia or leukemia, like they have pancytopenia. So it's one of the differentials of leukemia and aplastic anemia. So one of the differential could be vitamin B12 deficiency. Serum vitamin B12 levels are low, and the serum concentrations of methylmalonic acid and homocysteine usually are elevated. Excessive excretion of methylmalonic acid in the urine is a reliable and sensitive index of vitamin B12. This is the reference range. The treatment is hematological symptoms respond promptly to the parenteral administration of 1000 microgram vitamin B12. Oral administration has also been found to be equally effective in achieving hematologic and neurologic responses in adults, but the data is inadequate in children. Thank you very much, and you are welcome for any question if you have, and you can split this presentation in different parts, and you can again listen to the presentation in 2 to 3 parts so that you can absorb it conveniently. Thank you very much. Thanks.